Okay.
Okay, good morning, everyone. Today I will take our presentation. Now my topic is thinking caused by delayed recognition in a patient with middle cerebral artery occlusion. And my name is Yuan Ming. You can call me Dr. Yuan, and I'm the monitor of our class. And I come from the Jiangxi Provincial People's Hospital of China. Today I will present this case. This is a 66 years old male with hypertension for 2 years, and had a history of diabetes for 1 year, and had an older local infection for 3 years. The patient was admitted to the neurological emergency department at 10 o'clock 13 in the evening on May the 9th, 2021 because of paroxysmal unclear speech for 1 day, with weakness of the right limb for 10 hours. The patient and his wife said that the patient had sudden speech confusion, low limb weakness, dizziness, and headache at 3 o'clock in the evening on May the 9th, 2021. The above symptoms were relieved about 1 hour later, but not diagnosed and treated. On May the 9th and 12 o'clock, the patient had another attack of unclear speech, scalded mouth, with weakness of the right limb, difficulty to hold chopsticks, walking and jogging stable. The local had MRI and MIA suggested acute infection in the left cerebral hemisphere and subtotal occlusion of the left middle cerebral artery. The patients were treated with anti-plantar aggregation, liquid regulating, and plaque stabilization therapy, and come to our hospital for further treatment. Now let's see the physical examination. The blood pressure is higher, and the BMI is 20.6. The nervous system is show that his clear mind, incomplete official, and shower local screws on the right, thumb extended to the right. The right muscle strength was about grade 5. The left muscle strength was normal. The tender reflex was normal. The right buccal thumb was positive. Limb pain and superficial extension sensation was normal, and the bubbling skin thumb was negative. And the MRI score before 130 was 0. The drinking water test was normal. The total least score is just 4 scores. We can say and the facial paralysis is 1 total score, and the language 2 score, and the articulation is 1 score. Now let's see the video of the patients. From the video, we can see his hands and foot is normal. And we also see the laboratory inspection show that his blood test and the blood loading and the blood culture are normal, and the liver and the kidney function is normal. And the electrocardiogram showed a high voltage in the left ventricle. And we now see the MRI and MRA results of the head in the local hospital. We can see in the picture that in the left hemisphere, we can see acute infection in the left hemisphere, and the subocclusion on the left of the left middle cerebral artery. Now we diagnose these patients with, and firstly, the left middle cerebral artery occlusion cerebral infection, and the left middle cerebral artery occlusion. And 3 is hypertension disease, and 4 is type 2 diabetes mellitus. Now we think that how treat these patients, and with the drug therapy or emergency mechanical thrombectomy, means that drug therapy or the operation. Now let's see the guidelines in the ischemic stroke. We see that the medical sonography of the recycle stents should be performed for patients who meet all the following criteria: pre-stroke MRS score 0 to 1, and ischemic stroke is caused by a growing of internal cardiac artery of M1 segment of middle cerebral artery, and age should be 18 years, should be more than 18 years older, and the lead score and aspect score should be more than 6 score. But our patients is just 4 score, but it's just 4 scores. So it is not satisfy the gradation. So we chose the medical treatment for these patients. And now now let's see the treatment process of the patients. The first day we use the anti-plantar application, use the aspirin and chloroquine, and with the tirofiban and hapcheni injection and other symptomatic supportive therapy. And in the second day, the aspirin was suspended and changed to chloroquine combined with tirofiban, for anti-plantar therapy, plus an expansion and 4,000 units of anti-core therapy. And on the third day, we used the anti-plantar aggregation and with the as well as the in-6 aspirin for 3,000 units and anticoagulants therapy twice a day. But when on the first day, the patient was aggregation. The weakness of the right limb was aggregated. The simple language could be understood. The physical examination indicated that the mind was clear, incompletely official, and the muscle strength of the right limb was grade 1, and the muscle strength of the right lower limb was grade 4. Now, the current lead score is 10 scores, and it is aggregation with the admission of the hospital. Now we see this MRI of the patients on the 12th, the 4 days of the admission. And there were multi-acute cerebral infarction in the left cerebral hemisphere. We can see the right thumbs and a growing of the distal M1 and the east branch of the left middle cerebral artery, and the decreased blood perfusion in the left cerebral hemisphere and the right cerebral hemisphere. And this M1 distal is growing. So we think that these patients continue drug therapy or emergency mechanical thrombectomy. So we discussed these patients before operation. At this time, we think that we should choose the operation this time. So we take a discussion with these patients. Firstly, the judgment of the surgical adaptation times. Now the patient is the early male patient with progressive cerebral infarction was still aggregated after 4 days of double anticoagulation and anticoagulant therapy. The pathogenesis considered middle cerebral artery stenosis and a growing in situ. Proprio MRI perfusion showed no perfusion in the left cerebral hemisphere. And the surgery strategy, we plan to use a micro catheter to pass through the occlusive segment and to undergo balloon dilatation of the left middle cerebral artery and stent implantation if necessary. And the possible risk during the operation is surgical dissection, hyperperfusion, bleeding, reocclusion. Preventive measures are to and subjective control blood pressure after opening to avoid the occurrence of the hyperperfusion. Now let's see the surgical procedure. In the left picture, we can see that the localization of the left mid-cerebral was performed in the on May 12th. The first of all, and cerebral artery showed that the branch of the mid-cerebral were cold. Now let's see the video. Oh, it's a problem. Sorry. Okay. Again. Okay. Now is our macro gather to while to carry the macro gather through the occlusion. And the macro gather anti to in the chew artery, replacement of certain macro wire. And now let's see the blur of the after the operation. Now see this shape. We can see that in the picture. We can see that the blaster is very well. And this video is also as well. Okay. Now let's see the positive operative condition of the patients. The first day we can see that the patient's the least score is 10, and the third day after operation it's also 10 score, and in the seventh day we can see this score is in the 7 total. And after operation, we use the copidogrel and 75 mg and 1 day combined with the telophen 5 mono and anti-planes of the canny 3,000 units and anti-glow therapy. And when the patient is discharged from the hospital, we can see he is clear-minded and the speech is slightly ambiguous. The muscle strength of the right limb is 5 greater. And we can see this least score is just 3. And the MRI score is 2, and it is very well combined with the hospital. And now we also re-examination the head MRI with the hospital. We can see his MRI is well, and the CT is very well and not bleeding. And the anti-blocker was taken over at its discharge. We used the trigger tables 5, 16, and 19, and 1 tables and aspirin with the once a day. And patients were instructed to follow up regularly. It is planned to re-examine the DSA 3 months later and then decide whether to place sustain or not. And now we should discuss that should intravascular treatments be required for acute macrovascular occlusion stroke with least score less than 6 within 24 hours of onset. And the 2 question is that how to deal with stenosis after balloon dilatation of the macrovascular stenosticker and cerebral infarction. Now let's see the review of the article. And this article is published in the JAMA Neurology, and it is medical management versus the mechanical cerebrectomy for mild stroke. And it is also a meta-analysis. In this article, we can see that it is this article shows that the benefits of the medical, it means that the medical treatments and the mechanical cerebrectomy in stroke with acute macrovascular occlusion with least score and less than 6 are unknown. And this endpoint is shown that effective and safety, including the 3 months mortality rate and the symptomatic and symptomatic cerebral hemisphere. And this result should also show that it is not unknown of the results. And we can see the baseline data of the population. And it is shown that the county smoking from the two group is different, and the list of admission and the prognosis is also different in the two group. And the effective and the security outcome is also show that, and as symptomatic cerebral hemisphere and discharge leads and discharge MRIs is also different in the two groups. And as well as the function independence. And we also showed that there was a correlation between MDA and high as symptomatic interfaction hemorrhage. And we can also see that there was a correlation between MD and 3 months low infection independence, but there was no statistical difference after correlation analysis, and there was no significant difference in other efficiency and safety outcomes. And in this article, we can conclude that for acute microvascular conclusion with less than 6, the outcome of and the medical treatment and the operation is similar to that of the operation, and we should take further lesson and conclude just to lead a leader in the future. And let's see that too. The other question is that how to deal with the risk of the burden and dilatation of the macrovascular and sclerotic cerebral infarction. And we also see this article in the valve chair and lifespan 1 year vascular events and neurological outcomes. And in this article, we can see the results in the with 129 normal patients, and it is with 1 year events incidence, and show that 4 occurred with 25 loss, and during the 1 year follow-up, there are 7 new strokes and no deaths. And this study, this distribution of the disaster vessel instance of the stroke of the reticulosis patients were followed up by imaging. And this article showed that the reticulosis rate was 17.6, and they have an 18 reticulosis, and also among them also have the 11 cases were asymptomatic, and 7 cases were treated with double antiplatelets, and 2 cases with stain, and 2 cases with ballon and damage. And it is how and also have different results. So we also choose the Chinese article and also show that in the reticulosis rate of less than 15% is defined as a successful operation, and in standing relation is defined as a stand. Normal stay are more than 15% at least 6 months later after operation. And early application means that it have 4 cases, and means the 6.5%. And average imaging follow-up period is 7.9 and 3.3. The reticulosis rate is 6.5%. All of them 1 meter, and the lower segment stenosis of bathymal artery. And we now see that the basis study is ongoing research. So we can now see that the strategy of the endovascular treatment of symptomatic intra-artery stenosis remains to be discussed. I hope in the future we'll have a good method for these patients. My presentation is over. Thank you.
Thank you very much.
Thank you.